Welcome to the first film. My name is Yara Alsher, and I serve as the Executive Fellow in Education at APHA, and I'll be the host for today's episode. In part one, we covered everything from getting antiplatelet therapy right at discharge to navigating non-statin options for lipid lowering and ensuring patients stay on track with cardiac rehab and secondary prevention. Today, we're joined by Joseph Saseen, a clinical pharmacist and expert in cardiology and population health. Our focus today is on ASCVD risk reduction and the pharmacist's evolving role in cardiovascular care. From lipid management to antihypertensive optimization, pharmacists are uniquely positioned to improve outcomes at every stage of care. I'm really excited to have you here today, Joseph. Welcome to the first fill. Before we start, could you please introduce yourself to our listeners and share a bit about your role and responsibilities?
Sure. Thank you for having me. My name is Joseph Saseen. I'm a professor and associate dean for clinical affairs at the University of Colorado Anschutz School of Pharmacy, or the SCAG School of Pharmacy to be specific. We're in Aurora, Colorado. My job duties and responsibilities are a mixture of everything from educating pharmacy students and medical residents within our Department of Family Medicine to providing clinical care within our family medicine clinic where we see patients that are usually post-discharge or in sort of the chronic care mode where they're reducing their risk of cardiovascular disease. And also, I oversee the clinical affairs for our School of Pharmacy and work with our embedded pharmacists in primary care. We have some pharmacists embedded in specialty clinics. And also, we have pharmacists who are faculty members who are part of interprofessional teams in acute care settings, such as our University of Colorado Hospital. So that's me.
Welcome. So let's dive in. After an acute coronary syndrome or ACS event, getting blood pressure under control is critical. Pharmacists are often in the best position to optimize therapy, whether it's just adjusting doses, recommending new agents, or even identifying side effects. Joseph, what strategies do you use to manage post-ACS hypertension?
I think some of the strategies that we use are not necessarily unique to the post-ACS population. We can use similar strategies to any of our patients with hypertension, but I think there is sort of a perfect moment where patients soon after their acute coronary syndrome, they're very motivated because they know what the end point is. So unfortunately, we're in the mode of treating them to prevent what they just experienced versus something that might be theoretical. So some of the strategies that I think are most effective is not to scare patients, but to really emphasize that what they did experience, we want to avoid a recurrent episode. And also highlighting that recurrent episodes, to be honest with our patients, recurrent episodes often don't go as well as the first one, and that increases risk of not only mortality, but also morbidity, such as the development of other cardiovascular diseases, such as heart failure. I think some of the strategies are really level setting and being realistic with our patients, establishing what our shared goals are. I think there's this huge concept that we have. The American Heart Association promotes shared decision making. And it's sort of cliche. Of course, we always want to partner with our patients and have them in the center of our care team. But I think this unique situation where we can highlight sort of the potential long-term benefits of controlling blood pressure are perhaps a bit more meaningful. And it also is nice to highlight that not only will the medicines that we use to control hypertension improve their blood pressure, because of the history of ACS, many of the medicines that we use are really proven to reduce the risk specifically in the ACS population. So we can marry sort of the best of all worlds of prevention and then treatment, full recovery from that acute coronary syndrome.
Thank you for sharing your strategies. Now we know adherence drops off fast after discharge. What are your go-to strategies to keep patients on track after an ACS, and how can pharmacists make measurable impacts in this space?
I think we've seen a lot of momentum with pharmacists being involved in transitions of care. And what better situation than a patient who is admitted for a cardiovascular cause, whether that's heart failure or an acute coronary syndrome or an acute stroke or something else cardiac related, to really help them transition to their chronic outpatient care, which in this case would involve cardiac rehab. But I think some of the best strategies really are having a pharmacist comprehensively review their medication profile before they're discharged and really sometimes ensuring the basics. And the basics really are that fills or refills are available for the patient, that they get it from the same pharmacy ideally, that their meds are synchronized so that they don't have to refill medicines at different time points. We sort of overlook that one because sometimes just having, to speak on behalf of personal experiences with my parents, that when they have their medicines refilled at different times, it gets extremely confusing. Even if there's mail order services, that doesn't always make things better. It could be problematic when medications are not synchronized. And then I guess lastly, some of the basics are ensuring that your patient understands their medicine. I think if they do understand the overall purpose of their medicines, they have more of a reason to engage in them since we're talking about very beneficial treatments that have high levels of evidence according to the American Heart Association, American College of Cardiology guidelines, having a patient understand not only sort of the short-term gains, such as lowering blood pressure or providing antiplatelet therapy or controlling of other comorbidities like diabetes, but really the proven benefits of reducing future events and morbidity, mortality really is meaningful, and ensuring that they're accessible to your patient, not just that they get the medicines, but they're affordable. We are living in a world of cardiology where many of our core treatments are extremely affordable generics, which is a great thing. But every once in a while, patients do have eligibility for more expensive, perhaps prior auth medicine, and ensuring that they do have that available. I think we should never make the mistake that just because somebody has health insurance and pharmacy benefits, that means that medications are accessible. It doesn't always mean that. Sometimes their coverage is not accessible to them based on their benefit structure. So ensuring all those things. And I guess I'd wrap it up in the routine pharmacy duties is really just having a good conversation with your patient and providing the other routine elements of patient education, which does include all the lifestyle modifications that patients should engage in, which are physical activity when appropriate. Where this is not a population where you tell them after their acute coronary syndrome to, exercise vigorously for 150 minutes a week. This is not the time to do that because they should be in cardiac rehab, so we can defer some of that. But healthy eating is always something to emphasize, as well as the other elements of knowing their medicine, such as what to expect, how to use it, and what the medicines are for.
Yeah, I 100% agree with you, especially if patients really understand the medications, you see a difference. So thank you so much for sharing. Um, and I know there's a huge opportunity for pharmacists to intervene with patients when they have type 2 diabetes also, as well as ASCVD. So can you walk us through how you approach these cases and what's the pharmacist's role in integrating SGLT2 inhibitors or GLP-1 receptor agonists into the cardiology care plan?
Boy, this world of sort of managing cardiometabolic or cardio kidney metabolic disease has exploded. I guess when I approach it, I think of it from a few perspectives. Patients who do have diabetes are at risk for cardiac disease. That's the primary cause of death. So that really should be very high profile in the forefront of our minds when we're managing a patient with diabetes, that we have to manage cardiovascular risk. And some of the core components of cardiac rehab in the new guideline that was just published by AHA and ACC for acute coronary syndromes, when they talk about those core components of cardiac rehab, it's not just the routine things like patient assessment, nutrition, and weight management, but it does include, as we've talked about, blood pressure, lipid management, and diabetes management. So it's in the forefront of our brain as far as important things to think about with our patients with type 2 diabetes. Now, the days of starting with old traditional therapies are gone. We do not start with sulfonylureas. That went away, decades ago. But even, when patients are far from their goal, this population, while we're sometimes tempted with some of our older treatments to focus just on glucose control, the long-term benefits of the SGLT2 inhibitors and the GLP-1 receptor agonists really are quite robust. While they may not have a high-level independent recommendation in the ACS guideline, where they are highly evidence-based, are in our population with atherosclerotic cardiovascular disease. We know that GLP-1 receptor agonists and SGLT2 inhibitors both reduce future risk of recurrent events in patients with a history of ASCVD. So they're both evidence-based. And matter of fact, even with SGLT2 inhibitors, their benefits extend beyond just ASCVD, where they have very significant kidney benefits, benefits in heart failure, in many types of heart failure. And we can extend some of those benefits to the GLP-1 agents too. But both are important, both for glycemic control in our patients with type 2 diabetes, but also for long-term benefit. And that's really where the accessibility comes into play. I'm extremely disappointed that SGLT2 inhibitors have been generic for about a year, but they still are extremely expensive and not affordable to the average patient without assistance, meaning insurance. And that GLP-1 receptor agonists, obviously, everyone except for liraglutide is available brand name only and still are quite expensive. So we have to use these medicines for long-term benefit, but we have to balance that against what's accessible to our patient. When we think about in our patients with diabetes and cardiovascular disease, not only do we have the backing of long-term proof with using these drugs, we can use them both together. We can use one at a time. We can use them in combination with other traditional agents like metformin, which is really important also. But when we think about tolerability and educating patients, there's a variety of different things that patients know about with these medicines. They often have a very positive connotation to GLP-1 receptor agonists, but it doesn't mean that it's a positive connotation and perception of these drugs because of tolerability, because there are tolerability issues and a lot of titration that's needed with GLP-1 receptor agonists. So we have to think about that so the patients don't have intolerable side effects related to GI side effects. We have to use these drugs the right way. And SGLT2 inhibitors are really a bit easier to implement, but we still have monitoring concerns, not necessarily as much for major side effects, but really for hydration issues and overall tolerability. We're not expecting hypoglycemia like we might expect with some glucose-lowering medicines that we use in type 2 diabetes. But overall, when I look at these drugs, they should be used in a majority of our patients to manage both diabetes and cardiovascular risk. We have to use them prudently, dose the GLP-1 receptor agonist in a particular fashion. Since we can't get to the maximum dose right away, we have to base it on tolerability, be aware of the monitoring that's needed for tolerability issues and even weight loss, which can be of benefit in this population too. So I'm a big enthusiast, but I really am enthusiastic because of the long-term benefits.
Thank you for sharing your perspective. And finally, let's shift gear and talk about leadership, not just in clinical decisions, but in shaping care. Pharmacists play a key role during care transitions and in long-term follow-up. So from your perspective, what does it look like when pharmacists truly lead in advancing evidence-based cardiovascular care, and how can we further elevate that role?
Yeah, that's a great question. I think we need to sort of lean into heavily into the medication end of the domains of patient care because we are the experts in medication use and medication optimization. I think leading is really keeping the patient's best interest in mind. So leading with quality, and that many of these medicines that we have evidence-based recommendations for, putting cost aside, even though I don't want to discount cost, I want to just put it aside for right now. Using these medications sometimes in themselves are quality measures. And another way to look at that is, for example, patients with acute coronary syndromes or secondary prevention patients. One quality measure is how many of them are in high intensity statin therapy, since we know that's a proven affordable treatment. So pharmacists can lead by looking at those metrics and ensuring that in your patient population, this is sort of the spirit of population health, that your population is cared for appropriately. So proactively looking for patients that are falling into care gaps, and one of those care gaps with ACS might be how many people are not on high intensity statin therapy and identifying them and proactively intervening. You can do some of this with transitions of care. I mean, I think a great quality initiative is to have your transitions of care team not just ensure that patients are educated about their medicines, but that the medicines that are prescribed on discharge are the appropriate ones, not just from the choice of agent, but the dose. And that's the case of high intensity statin therapy in our patients with ACS. Especially if they have other comorbidities. Another way beyond just use of the appropriate medicines is getting people to their goals. While we don't have a quality measure currently related to cholesterol, We do have quality measures related to glycemic control in our diabetes population and blood pressure control in our hypertensive population. So pharmacists can lean into and lead by implementing pathways and programs which help our patients get to those acknowledged and recognized quality endpoints. And with those comorbidities, it's really controlling your population with diabetes to acceptable A1C goals and also to acceptable blood pressure lowering goals. I think that the leadership comes by um, accepting responsibility. I find sometimes that the old term pharmaceutical care, which I don't love that term. I usually just view it as quality pharmacy care or clinical care provided by pharmacists. Whatever term you want to use is really accepting responsibility for your population, not just responsibility for appropriate medicines dispensed in an appropriate quantity and dose, but that second step of really being responsible for the quality of your patient's care. I think that is demonstrating the leadership that's needed to improve the health of our populations.
Thank you so much, Joseph. And I agree with everything you said. Thank you for joining us today and sharing your expertise. This has been a thoughtful and inspiring look at how pharmacists can lead to improve outcomes in cardiovascular care. All right, let's summarize major takeaways from our time here today. Pharmacists play a vital role in achieving blood pressure targets after an ACS event by adjusting therapy, recommending appropriate agents, and monitoring for side effects. Medication adherence tends to decline quickly post-discharge. Pharmacists can close that gap by offering tailored education, simplifying regimens, and coordinating follow-ups. All right, folks, that's all for today's episode of The First Fill. If you missed last week's episode, we highlighted the 2025 ACC/AHA Clinical Practice Guidelines for the Management of Acute Coronary Syndromes, so don't forget to check that out. And as always, don't forget to visit the Learning Library at pharmacist.com to earn your CE credit for this month's podcast. We'd love to hear your feedback on the new format. Take care, and thanks for listening.